Welcome everyone to Healthcare for All, brought to you by WCANradio.com. This program examines the issues of healthcare for you. Join us now in the studio where the program is in progress.
Good evening and welcome to Healthcare for All. This is Debbie Silverstein, your host, and we are in the WCAN studios. Healthcare for All is sponsored by WCAN Radio in support of Span, Ohio. I'm here with Tim Sember, my co-host for tonight. Tim is standing in for Eric because Eric is out of town. Hi, Tim.
How you doing, Debbie?
I'm good. How are you?
Doing excellent. I'm looking forward to tonight's show because there's a lot of things to cover here and talk about for this healthcare, because looking at some of the actual, how could you say, numbers for this country where we stand at, it's not looking too good for us. We're paying too much money, but we're at the bottom of the barrel.
Oh, yeah, we are. Tim, this has been, doing this show with us, you know, Tim is normally our engineer on the show, and doing this show with us has been a real education for you.
Big time. I'm
not sure where you were on the whole issue of healthcare, if you even thought about it before we got started on this show, but you know, program after program after program, you've been amazed by the information that we've presented.
Absolutely amazed, and the guests we've had have been so knowledgeable. It's been excellent. I've learned so much about what's going on, and you know, I'm even concerned for my own self as I get older, because when we get older, we need more medical attention.
Right.
So,
right.
Looking at everything happening right now, I see that something needs to be done soon.
Right.
I mean, I don't want to just speak for myself. This has been going on for a while, but for everybody, you
right.
know, it's getting worse. And this country, not to keep it going, you know, keep it rambling, but this country has a pretty bad rate as far as being health-wise, being healthy, as far as, because, you know, a lot of people don't take care of themselves as well as they probably could, and that actually adds on to it too. But there's different things to it.
And yeah, and a lot of people don't have the knowledge and they don't have the resources because we close the door to them when it comes to getting that through actual access to health care. Well, tonight we've got an interesting program. Our guest is Benjamin Day. He's the Director of Organizing for Healthcare Now, not tomorrow, now. And he came from MassCare, which was a single-payer organization in Massachusetts, and he was there when Massachusetts enacted their health care reform law that the Affordable Care Act was patterned after. So he can tell us a little bit about what to expect from that. Hi, Ben. How are you?
I'm doing as best as could be expected coming from Boston this week. So thanks for having me on.
That is, you know, and that was one of the things I think Donna Smith made the comment that she certainly hoped that those that were taken to the hospital were not first asked about their insurance and how they were going to pay for their care. That they at least hoped, she hoped that they at least had the wherewithal to treat them first and wait a day before they got into that.
Yeah, they did, but there's already fundraising going on to pay for medical bills for some of the victims. So that couldn't happen in any other developed world except ours, where you have to do fundraising for health care of the victims of the horrific terrorism attacks. So.
Well, and the same thing happened in Colorado in the theater shooting, that there were a number of those that were uninsured or, you know, not insured as well as they probably needed to be. And there was a lot of fundraising that was going on there. And, you know, you're right. It's only in this country where victims, you know, face bankruptcy because of a misfortune like that.
Well, our thoughts are definitely with you here in Ohio, too.
Exactly.
We are very sorry for what happened.
And, you know, there really is no way to explain it. It's just a horrific thing. But one of the things, you know, the quote that's been going around is from Mr. Rogers, and it sounds simplistic, but he said as a child his mother always said, watch the helpers, watch the helpers. And that is probably the most shining thing that's come out of this, is the help that Bostonians gave to those that were involved, you know, that were victimized by this. People opened their homes to those that were stranded. They paid taxi fares. They did everything they could in the most generous spirit that you could find, and that is really a tribute to the people of Boston.
Yeah, I mean, it's really it's a relief, these rare moments where politics sort of fade away and you know, racial divides and ethnic divides and immigration status all sort of fades away in the face of just really horrific crisis. and you sort of wish we could have that more often.
Right.
And the jobs I've had for the last 8 years, I mean, the healthcare system is horrific. I mean, it does horrible, horrible things to people too, but it's sort of a quiet horror that each family and each individual has to struggle with on their own. So we don't get the same public reaction that we do at these times of just abject, public terror. So
right. Well, what happened in Boston was a public act of evil.
Yeah.
What happens on a daily basis to people in our healthcare system is not a public act of evil. It's a personal act of evil against them. And many people keep it quiet because they're embarrassed. They're ashamed that they aren't able to provide better or to take care of these situations better. And it really denigrates the person. It's a very dehumanizing process and system that we have here.
Yeah, I agree.
So now let's go to the Massachusetts experience. Massachusetts passed a health care reform bill under Governor Mitt Romney. He tried to distance himself from that and its similarities to the Affordable Care Act. But the Affordable Care Act basically was based on the Massachusetts plan, wasn't it?
Yeah, it's similar in most of its details,
okay.
if not all details.
Are there any differences that are glaring or striking?
No. I mean, I think the most glaring thing is the similarity of the structure of these. I mean, states for many, many decades have been trying to solve the crisis of uninsurance and underinsurance. And mostly the way they've been doing it is through expanding our public health insurance plans like Medicaid, expanding Medicaid programs. So we've had a lot of examples of, we had TennCare in Tennessee, we had Minnesota Health Care, a lot of plans nobody's ever heard of anymore or doesn't remember, or they were in the headlines for, 2 weeks and then they were gone.
Right.
I mean, over a dozen states have tried to eliminate the lack of insurance coverage through expanding public programs, and they've all failed. Some of them didn't even succeed in expanding insurance coverage at all. So the only thing new about the Massachusetts model, it's mostly that. It was mostly a public expansion. So it's actually largely in the vein of what we've tried to do already. The biggest significant difference was that they added this individual mandate, which fines individuals above a certain income level if they don't buy health insurance on their own and prove on their tax forms that they have health insurance. So that's sort of the new thing, the public subsidies that are created for low-income people, that we've done that before in a number of states, and that's the model. It's sort of in theory, the idea is we're going to cover all of the uninsured, or at least a lot of them, for the very low income, offering public health insurance and subsidies, and then for those who are higher income, forcing them to buy their own health insurance. And around that is the whole rhetoric, sort of blaming the victim in this case, sort of blaming the uninsured, saying, well, you have enough money to afford it. You should be assuming individual responsibility, so we're going to fine you if you don't.
Well, how did they determine affordability? Because I looked at the Massachusetts Connector and the policies that they offered there. I didn't find anything that was very affordable. Yeah,
so both in Massachusetts and nationally, there's a deep, deep problem with how they calculate affordability. And the biggest problem is that they only use healthcare premiums.
Right.
To decide what you can afford based on your income. Acting as if you're going to buy a plan that has no deductibles or copays. So under the formula they use and that they're going to use nationally starting in 2014, you can be forced to buy health insurance that they've determined that you're able to afford the premium of, but you could end up with a very high deductible plan and then not be able to afford to actually use the insurance coverage that you bought. I remember there was when the Massachusetts plan passed, there was a Maine activist who told me, he sort of commented that the only thing worse than being uninsured is being forced to pay to be uninsured, which is effectively what happens for a lot of people in this situation.
Well, now this is interesting. Mark Dudzik from the Labor Campaign for Single Payer calls the Affordable Care Act, and probably the Massachusetts one as well, a race to the bottom. And he calls it that because when you're looking at the insurance policies, what they've done in the Affordable Care Act is they've kind of set the silver level as their standard. And the silver level, we're being Olympian in this. We've got bronze, silver, gold, but then we also add in the platinum at the top. And the silver level has what they call a 70% actuarial rate, meaning it should pay about 70% of your expenses. But that is a policy that is below standard. And they're setting this as the standard. You know, most people that have decent insurance have an 80 or 90% actuarial rate. There aren't too many of the 90% ones, but when I was working full time, that's what I had. And on the 80% one that I have now, I find healthcare to be somewhat unaffordable.
Yeah, I mean, our whole healthcare system, in a way, is a race to the bottom. Just because costs are rising so rapidly, that you know, this is the solution for employers, is to shift costs onto their employees by, you know, trying to keep premiums down, but increasing cost sharing through higher deductibles and higher copayments. And what happened in Massachusetts is interesting. I mean, there were definitely some positive aspects to the law, some very positive aspects. But one of the sort of unforeseen downsides is that underinsurance increased very rapidly right after health reform passed in Massachusetts.
Okay.
So right before the law passed in 2006, immediately before it went into effect, we had about 3% of people who had private health insurance had high deductible plans, which we define as having a deductible of $1,000 or more.
Okay.
2 years later, in 2008, that's just, you know, a year and a half into implementation of health reform, over 11%
Wow.
of people who had private health insurance had high deductible plans. So in a way, we sort of replaced this crisis. And for some of those people, of course, it's better to have a high deductible plan than to be uninsured.
Right.
But we did sort of replace this crisis. But, you know, we only insured about 5% of the population. So that's still a huge group who previously had good insurance that was moved into very poor sort of Swiss cheese type policies that don't really cover you very well. And a lot of that is in small businesses.
Right.
Who face the highest costs and have the least ability to afford coverage for their workers. So we sort of replaced this crisis of uninsurance with a crisis of underinsurance. And I think we can probably expect something similar is going to happen nationally.
Yeah. What I had read is that most of the policies sold on the connector were those high deductible plans, you know, the bare bones policies, because that's all people can afford.
Yeah, and we're forcing people to buy health insurance. So naturally, you know, there was an interesting study that was done, and I actually don't know if it was ever published, but there's a sociologist in Boston who did a study looking at people who were buying plans through the connector, which is our exchange plan. By the way, every state is going to have an exchange by the end of this year.
Right.
And, you know, as you say, you can buy a high premium plan, a gold plan that has better coverage.
Right.
Or you can buy a lower premium plan that has higher deductibles and copays. So this sociologist looked at what choices people make in terms of the plan that they choose, and then did a sort of a comprehensive interview of their medical history in the last 2 years. You know, what is every single hospital visit and doctor visit and all the prescription drugs that they use, and then calculated, you know, did they make the right choice? Did they pick the plan that's going to save them the most money?
Right.
And she found that everyone chose wrong.
Oh, no.
Almost everyone chose wrong because, you know, if you're lower income, you're going to buy the lower premium plan, even if you have medical issues that are going to force you to pay a lot of money in deductibles and copayments. So it's really this notion that we're giving people choice is really just totally ridiculous. And there's a lot of research around Medicare on this.
Right.
When they created the drug plan for Medicare, almost all seniors picked the wrong plan in the same exact way. So it's not a marketplace. It's not choice. We cannot turn patients into consumers because it's just it doesn't work.
Yeah, and you know what's interesting is we have seen the encroachment of marketplace language into healthcare. You know, we're no longer patients; we're called consumers of healthcare. And I guess they're going to change the exchanges to something like the insurance marketplace or something like that because, you know, the exchanges was confusing. And I really, really get upset when this marketplace language creeps in, and especially about being a consumer of healthcare, because it gives me a vision of hundreds of people descending on the local mall in their hospital gowns, crowding around the cosmetic counter, buying shoes, whatever you do in the mall, with your butts hanging out. And that's basically what they're doing to us on this coverage, is that they're leaving us with our butts hanging out. And stuff. But the other part of that is when they use this marketplace language, is that they are conditioning us to the marketplace. And in the marketplace, if you can't pay for it, you don't get it. So they're conditioning us to, well, you can pay for it, you live. You can't pay for it, sorry, you die.
Yeah. Yeah, I can see that.
Yeah.
And I think also I remember during national health reform, there was a sense that Democrats were trying to, preempt Republicans with their own language. A lot of the attempt to get the public option passed was sort of in that language, like we're going to out-competitive the Republican narrative of competitive markets. And then it's just sort of stuck. I mean, even the individual mandate itself came straight out of the Newt Gingrich program. So there's a lot of sort of trying to borrow conservative ideology from liberals to get something passed to sort of outsmart the right. But then you're stuck with your own language, 2 or 3 years later.
Well, and that's, where Max Baucus, who is head of the Senate Finance Committee, who basically wrote most of what's in the bill, he's found himself in that position. And I read an article today where he has come out and called the Affordable Care Act a train wreck. And yet he created the train wreck. And he's trying to distance himself from what he did in that. Tim, you had a question.
Actually, just a statement. With paying for premiums, I work for a major corporation, I guess you could say, an airline. And it's funny, my wife and I, she can get insurance through her job where she works, but she chooses just to be under me. And I chose a plan where it covers me and her and my daughter, family and everything, and everything looks great. I'm paying that monthly premium, but I'm also getting charged an extra $85 a month because she chose not to choose her health care. And it's absolutely amazing how these insurance companies just completely do what they want to do and charge what they want to charge.
Well, that may be your employer charging you the extra
Or maybe
85.
it's the employer. I'm not sure how all that, because sometimes when I'm picking healthcare, I'm like, exactly what you said earlier. Sometimes you make the wrong choices. So I'm looking, going,
well,
what can I afford?
And see, your employer doesn't want to cover anyone that they don't have to cover.
Right.
And especially if your wife is of childbearing age, they're expensive people. If you should happen to have another child. And so what they do is a lot of companies try to discourage you from covering spouses and family members, and there's some that will not cover them if they can get it through their own employment. They refuse.
Oh, wow. That I didn't know. I mean, they're not doing it where I work, but they do charge you that extra fee because even though I chose a plan to cover her, but they still charge me that extra fee.
Right.
Because of that, and sometimes I just scratch my head going, wow, that's amazing.
Yeah.
Just
well, see, but then the thing is, it used to be every member of the family was under the same plan, and now because of what we're doing and the costs that are associated with it, you could have every member of the family under a different plan, and think of how confusing that is, because your plan's not the same as your wife's, it's maybe not the same as what your daughter has, and what's covered for you may not be covered for your wife, and vice versa, and does the normal person get confused? I think so.
Exactly, and what they provide, Aetna, Blue Cross Blue Shield, which I do like them. I always thought they were a good plan, but I just can't afford that Blue Cross Blue Shield. They're just too expensive for me.
Right.
And it's something's got to be done one of these days because it's really bad. It really is.
Yeah. Ben, what happened in Massachusetts when this law went into effect on costs of health care?
So costs did go up, especially for small businesses. Costs were already going up significantly.
Right.
And we did see a bump in a slight. It was increasing a little bit faster after health reform as opposed to before health reform. It wasn't a huge impact, just because the new health law. And this is going to be a little bit different nationally. In Massachusetts, a lot of what are called market reforms, that is sort of regulating the insurance companies and sort of the dirty tricks that they can play. So, not letting them exclude people based on pre-existing conditions.
Right.
banning things that are called rescissions, which basically means when you get sick, your insurance company drops your plan retroactively back to before you got sick.
Yeah. Mm-hmm.
Those things were all illegal in Massachusetts already for decades.
Uh-huh.
So our health reform didn't have all those parts of it. Those things are going to increase premiums. They're not going to increase healthcare costs. Because they basically mean that, people with pre-existing conditions are going to have to be covered, so they're going to be included in your insurance pool, and it's going to drive up everyone's premiums.
Mm-hmm.
That's not increasing costs because those people with pre-existing conditions would have to pay for their costs on their own previously, and now they're just joining the pool.
Mm-hmm.
But in Massachusetts, even without all that, we did see a premium bump, and a lot of it we found was driven by administrative growth.
Okay.
Because the rule it introduces all these new complex rules, and we already know that most of the waste in our healthcare system is because of our administrative costs relative to other countries who have a universal public and health insurance plan for everyone.
Mm-hmm.
So, even when we're doing good things, when we're extending new insurance, public insurance to the uninsured, we end up adding layers of complexity and adding a new plan that administrators have to deal with.
Mm-hmm.
So there's a whole research article that showed that we had this big bump in administrative growth
mm-hmm.
in Massachusetts, and that is probably one of the things that started driving up our costs a little bit more. So that's sort of a fundamental problem with trying to tackle the problem of our our dysfunctional healthcare system by adding on more and more programs.
Mm-hmm. Well, and the biggest part of our whole healthcare system is we don't have a system. We've got a dozen different systems working at once, all with different rules and regulations and payment schemes and ways to get reimbursed and that type of thing. But we don't have any kind of a unified plan.
Mm-hmm.
And that's what causes a lot of the complexity and a lot of the problems.
Yeah.
Yep. And the problem is you as a patient, you may think you know what you've got, and what's covered. And the doctor may think they know what's covered and that type of thing, and then you're both surprised when it isn't.
Yep. Yep. No, I mean, we have if you're a physician or a hospital, I
mm-hmm.
mean, you just have to deal with hundreds of different insurance plans, and each of them has a different set of rules. Each of them cover different things. They have different copays,
mm-hmm.
Different things, drugs that they're allowed to cover, that they're not allowed to cover. So it's just, I mean, there are hospitals that have more administrators than nurses.
Right.
I mean, it's shocking how much money gets thrown at this, and we keep making it worse and worse. And the administrative side of our healthcare system, which adds nothing to patient care, by the way. It doesn't improve quality of care. It doesn't improve access to care.
Mm-hmm.
That keeps growing more and more every year. And the things that actually do improve access to care and quality of care shrink relatively,
mm-hmm.
Given how much we're spending. So.
Well, one of the statistics that I looked at that was pretty striking is that after the Massachusetts reform took place, yes, the number of uninsured decreased, and you've got a small number of uninsured now because for some, no matter what, it's still unaffordable to them. But one of the things that happened is that there was an increase in the number of insured people who were not seeing a doctor when they needed it, not filling a prescription that had been given to them, and turning down, needed tests and treatments because of cost, and yet they were insured.
I mean, the last data I looked at, there hadn't been I hadn't seen that particular one. I mean, there's a national survey that the Centers for Disease Control run that looks at sort of access to care.
Mm-hmm.
And we know that there was a slight increase in the number of people who had sort of a regular source of care, like a doctor.
Right.
People who reported avoiding care due to costs also dropped a little bit.
Mm-hmm.
But it was a smaller percentage of the population than received insurance coverage.
Mm-hmm.
So we're looking more at like 2 to 3% of the population. So I don't know which study exactly you're referring to, but mostly we saw sort of a slight improvement in access to care,
right.
A significant improvement in insurance coverage, which is a totally different thing.
Mm-hmm.
And then this rise in underinsurance and rise in costs.
Yeah. Yeah, and one of the things, and we're going to be talking about this in the next program with one of the researchers, but a big point mm-hmm. is that despite the reforms, there was not a significant decline in medical bankruptcies in Massachusetts.
Yeah, there was no decline in bankruptcies.
Right.
And in fact, this is one of the most interesting things, because a lot of the things that we think of as sort of the worst things about our healthcare system, people are surprised to find out that they afflict mostly the insured, not the uninsured.
Yeah.
So medical bankruptcy mostly is people who have insurance at the onset of the illness that bankrupts them. Similarly, most people who have medical debt, most people have problems paying off medical debt and are paying medical bills over time. Those folks all have insurance, the vast majority of them. So when you approach health reform with the single goal of extending insurance coverage, whatever it is, to the uninsured, you don't get at a lot of these basic access problems. So after health reform, we documented that the share of people who are facing medical debt did not go down after health reform. Those who are facing medical bankruptcy did not go down after health reform. Those who are paying medical bills over time did not go down after health reform. And emergency room usage, which everyone assumed would go down, especially sort of unnecessary and preventable emergency room usage would go down, did not go down after health reform. It kept rising because that is also overwhelmingly people who had health insurance, but they come up with an issue that's on the weekend or at night when they can't see their physician, so they go to the emergency room.
Well, we're also seeing another phenomenon in that is a lot of policies now are tacking on that $50 copay for the ER now. So if you go to the ER and you're not admitted, you pay a $50 copay that does not apply to your deductible. And then the deductible kicks in, and and if you meet your deductible, then they will pay the 70, 80, or whatever percent. So a lot of people don't go because of that $50 deductible, and people with having heart attacks don't go. And we're finding an increase in that because that does restrict them. They tell people you have to be responsible for yourself, and and one of the things they tell us all the time is that we use too much care in this country, and that's part of the problem, that we abuse the care. And so people say, okay, it's gas, heartburn, and then they're dead.
Yeah, there's several important points you bring up. One is that we do not use healthcare more than other countries. We actually use healthcare on average a little bit less than our peer countries in the developed world. And
yet it costs twice as much.
Yeah, there's areas where we use more, but on the whole, and the main reason for this is that we have a large immigrant population in the United States. And immigrants are very healthy, actually, because generally they're younger, they've traveled, so they're mobile. So because of that, we actually have a generally healthy population, more healthy than most developed countries, and we use less care. But our costs are so high because of our dysfunctional healthcare system. The other thing is that when you have there's great studies that show when you have co-payments and deductibles, the only thing it does is it keeps people out of the healthcare system. It keeps people from entering the healthcare system to start with. Once people do go to the doctor, those with co-payments behave exactly the same as those without co-payments. Everyone listens to their doctor once they get advice. So the only thing that cost sharing does, that having financial barriers does, is it causes people not to seek help or advice in the first place, which is the opposite of what you want in any healthcare system.
Right.
It causes people to avoid necessary care and unnecessary care equally. It's really destructive for patient health.
It's the difference between what they call early presentation and late presentation. And those that present early usually can be treated more quickly, more easily, and more cost-effectively than those who wait until it becomes a crisis. And they're the expensive ones. And unfortunately, we have a system that encourages us to wait until there's a crisis. Yeah. Now, part of our system is our Medicare and our Medicaid programs. And yet those two programs are under attack. One of the parts of the ACA was to expand Medicaid. Here in Ohio, the governor included the Medicaid expansion in his budget, but the legislature, in its wisdom, chose to remove it from the budget. And this is actually going to cost Ohio money to remove the Medicaid expansion from the budget. It's strictly a move on ideological grounds.
Yeah, and that's happening all over the country. I mean, for listeners who don't know the details of this, the federal expanding Medicaid, they want to expand Medicaid to everyone up to 133% of the poverty line, so just above the poverty line. And the federal government is paying for 100% of it. So states have to pay for none of it in their budget.
Right.
And that means it's an incredible deal for states, because currently a lot of people who fall within that bracket are being paid half by the states or a third by the states. And this would mean that those folks who are already covered under Medicaid would be covered, but the entire budget would be paid for by the feds. So when you're looking at it from the perspective of a state budget, it is free, at least for the first few years. And down the road, states pay a tiny, tiny percentage of covering those new folks, like 10, 15%. So there is no conceivable economic reason for not performing this Medicaid expansion, but it's just being used as sort of a bargaining chip, literally, bargaining with people's lives in order to try and make the Affordable Care Act fail.
And let's put it this way: Medicaid it's not a perfect program. There are problems with Medicaid, but for the population that it will serve, it's better than what they have right now, which is nothing. And sometimes I think what we do with Medicaid is we deliberately make it a program with problems, and we make it difficult. But it's enough to salve our consciences to say that we've taken care of the poor. It's not really enough, but we can say we did it.
Yeah, there's a saying that programs for the poor will always be poor programs, which is why when you look at Medicare, for example, which covers everyone, whether they're low income or high income,
right?
It is almost 100% of doctors accept Medicare patients. It reimburses physicians better for treating Medicare patients, whereas Medicaid reimburses very, very low. Only about half of doctors accept Medicaid patients. So this is what happens when you carve off treatment for low-income people from everyone else. Medicaid recipients just don't have any political power. They're not a politically mobilized group that can, mobilize resources and lobby for themselves.
Right.
So they just end up being the victim constantly of cuts.
Well, pretty soon, though, that's going to be most of us, I think.
Well,
are going to be, the way things are going, that most of us are going to be there because, we've got an economy right now where the rich get richer and the poor get poorer, and the middle class is disappearing. So, we'll all be in that poor designation pretty soon. And we'll be in that underinsured, uninsured population soon, too. With the way things are going.
The healthcare crisis is moving up and up the income ladder.
Oh, yeah.
Every year, so.
Well, what we're finding is employers that are reducing the hours of their employees so that they're underneath that 30-hour mark, so they don't have to provide them with benefits. And that's not a new trick. That's an old trick. I can remember when we bargained in the school district I worked for, and we bargained to get health care coverage for the tutors. And, the mark was set at that 30 hours. Well, the school district immediately turned around and rescheduled all the tutors to work 29 and a half hours.
Yeah. It's a new trick, but circumstances are going to lead it to be used all the time.
Right.
And, if you look at, the retail industry, for example, that's a really horrible outcome for employees, just because in retail, workers can't get enough hours to make enough income to pay, to survive.
Right.
So it ends up, not only do they have the healthcare crisis, but now they also have an income crisis.
Well, and the very first guest I ever had on this show said that if he was king for a day, what he would do is eliminate poverty, because that would help to eliminate a lot of these problems that we have. And that.
Well, when Medicare passed, covering all seniors with not perfect health insurance, obviously, but everyone had some basic health insurance. It lifted tens of millions of seniors out of poverty. Just taking the healthcare burden off of them, which for seniors was a huge percentage of their daily expenses.
Right. Well, and think about that time of life. We're all going to be there someday.
Yeah. No,
hopefully. Absolutely. We're all going to be old people someday.
Yeah.
And
So, I mean, in addition to, of course, other things like housing and the cost of education, healthcare is one of the things that puts people in poverty.
right.
It's not, if you're a king for a day, it's not the only way to, it's not going to be enough to take everyone out of poverty, but it would be a big step.
Yeah, it would. But, it's Medicare and Social Security, those two together reduce the poverty level among seniors by, I think, about 72%. A tremendous reduction in poverty among our seniors. And we want to maintain that. Yet those two programs are under attack. We have deliberately, I believe the deficit was deliberately run up so that there would be a good reason to go after those programs.
Well, it is suspicious that although the Republicans have always had sort of an anti-government, anti-deficit rhetoric, it's always been under Republican presidents that the deficits get run up.
I know.
And Democratic presidents almost always reduce the deficit. But yeah, and the interesting thing about Medicare is, Medicare is in crisis, but it's in the same crisis that the rest of the healthcare system is in. Medicare is, because it's a public program, it's a bit more efficient than private health insurance plans. So it costs a little bit less to cover a senior under Medicare than it would to cover them under a private health plan. And the costs rise a little bit slower for Medicare than they do for the private health insurance companies, but the difference isn't huge, actually, and that's because of what we were talking about earlier, which is that, most of these high costs have to do with our complex healthcare system. How, hospitals and physicians have to deal with dozens or hundreds of different insurance plans, all with different rules, and from that perspective, Medicare is just another insurance plan.
Right.
So Medicare is not truly what we call a single-payer healthcare plan, which is, what most developed countries have. It is a public plan that covers all seniors, but seniors go to the same hospitals that everyone else does. So Medicare does have costs that are rising too fast, and their costs are too high. And in a way, Medicare is sort of in the same boat as the private insurance plans. And we're going to have to really overhaul the whole healthcare system if we want to save Medicare, or if we want to save the rest of us who have private insurance plans. So, we're going to reach a point where these, we run out of options. We're now recycling managed care tactics from the 1990s and trying to bring them all back again as if we didn't try them 20 years ago and they didn't all fail.
Yeah, we just repackaged them with a new name.
Yeah, exactly.
We're taking HMOs and we're calling them managed care now.
Yeah, but these healthcare costs are just, they're destroying literally everything in the American economy. So something has got to give, and it's not, the economic desperation is going to have to overcome our ideological differences at some point.
Well, I would hope so, but, when I look down at our legislators in Columbus, I have to wonder because, I have to wonder how anyone can be so cold-hearted. And they literally are. Because, we do know that with all its faults, Medicaid does save lives. States that have done voluntary expansions have seen a 6% decrease in mortality rates. So yes, you were right before when you said that they are literally playing with people's lives. And they have to be held accountable for that. I think we're a better society than that, but unfortunately they wrestled the power and we've got to take it back from them and hold them more accountable than what we do.
Yeah, I think what's really going to give eventually will be businesses.
Yeah.
I don't know how it is in every state. In Massachusetts, we have a huge healthcare industry in Massachusetts. It's about a third of the economy in the state. So we're fairly liberal, very, very democratic state, but that doesn't enable us to pass comprehensive cost control any better than other states because the healthcare lobby is much more powerful here than in most states. So what happens here is, most businesses who are getting killed by healthcare costs. Employers are just, anyone who has to compete internationally is being priced out of the market by healthcare costs in the United States. And it's just that's the reason wages are plummeting. I know we like to blame rising CEO pay and rising executive pay, which is a tiny part of it, but most of it is actually healthcare costs are eating up all of our wages, and that's why the middle class has flat or falling wages in the last 30 years.
Well, Ben, I just got the signal.
Okay.
We've got 3 minutes, and can you tell us in 1 minute, what does Healthcare Now do?
Okay, so Healthcare Now advocates for a national single-payer healthcare system, sort of like we've been describing, which every other developed country and a growing number of developing countries have adopted, which provides universal, comprehensive healthcare for everyone, and it costs half to a third as much in every single country except ours. So it's been proven by everyone but us.
Yeah.
It's not an experimental thing. We know exactly how it works.
Right.
So we just keep up this movement for comprehensive reform, and that's all we do. And we have chapters in many, many states that are affiliated with Healthcare Now, and we have a website, which is healthcare-now.org.
Okay.
And we do lots of national actions, and we're a grassroots organization, so we really believe in pursuing this from the bottom up. We hope folks will get involved, and we'll also get involved in SPAN at the state level.
Right.
But we sort of work with state groups to keep our eye on the national things that are happening, the national insurance companies that are trying to get away with murder, things that are happening in Congress, and we do lots of solidarity actions to help other states that are trying to fight locally.
Okay, and listeners can contact you through the Healthcare Now website, correct?
Absolutely. Yep.
At healthcare-now.org.
That's right.
Okay, next we have some announcements. One is Save the Date, and Ben, can tell us a little bit about this. October 5th through 6th, Healthcare Now is having a national strategy conference in Nashville, Tennessee. And who can come to this, and how do they come?
So everyone is welcome. This is going to be it's going to be at the Scarrett Bennett Center, which is near Vanderbilt University.
Okay.
This news is so hot off the press that we haven't even posted it on our website yet. But very shortly, in the next few weeks, we're going to have an announcement with details about it, and we'll have the conference registration fees and all that, which we keep extremely low.
Right.
And really, we want to just bring activists from around the country to talk about the healthcare organizing that they've been doing, or for newer folks to learn about how to organize. And we have all sorts of skills trainings, how to do media work, how to do outreach, how to do fundraising. So it's going to be a really exciting time. And we're really going to be focused especially on the implementation of national health care reform, which really kicks into high gear in 2014.
Okay.
And we're going to identify the key areas where people are going to want to organize around to build a movement for comprehensive universal health care.
Great. Well, I know I will be there. Other things, if you're in Ohio and you want to get involved, one of the things that you can do is Walk for Health with SPAN Ohio. We're holding walks in different parts of the states on different dates. In May 4th, we'll be walking in Dayton, on May 11th in Toledo, and on May 18th in Cleveland and Athens. So if you're interested in that, check the SPAN website for details, and that's spanohio.org, and you can get details of that and of other activities that are going on. Next month's guest will be Dr. Deborah Thorne. Dr. Thorne participated with Dr. Steffi Woolhandler and now Senator Elizabeth Warren in a bankruptcy study on Massachusetts after reform, and she's going to be talking about why people with insurance go bankrupt. How does that happen? Isn't insurance supposed to take care of us and prevent that from happening? And it's kind of surprising because it's those common diseases that get us the most. So we want to thank you for listening, and until next time. Thank you, Ben.
Thanks for having me.